Okay, I'm going to start with my machine check. I'm going to check my auxiliary O2, make sure that's at least half full, and close it. I'm going to check my pipeline pressures, make sure those are 50 psi. I'm going to look at my vaporizers and make sure that the caps are on tight and they're full, that the interlock is working here. While my machine's off, I'm going to do my low pressure leak test, make sure there's no leak in my flow meters. And then I can turn my machine on and make sure I can't create a hypoxic mixture. And that the link 25 is working appropriately. Then I'm going to do a high pressure test. Close my APL valve to 70 and close the Y-piece. I should be able to maintain 30 centimeters of water for at least 10 seconds, which I can. I'm going to look at my X-ray valves, make sure I can deliver positive pressure breath. Open my APL valve for my patient to be on spontaneous, and then I got my ventilator on. I'm going to have my vent settings set up for my patient's body habits. I'm going to make sure that my monitor has EKG, blood pressure cuff, and SpO2, and my suction's working, and that my ambu bag is functioning appropriately. I'm going to check my CO2 absorber, and I'm going to do my O2 analyzer test as well. And then I'm just going to turn this off so it doesn't annoy me. So I have my mask ready to go. And then I have my Apple's drugs as well. I'm going to be using Pro, Rock, and lidocaine and fentanyl for induction today. I have a 7.0 ET tube for my female patient and a half size below and above. And then I have my MAC 3 blade with me. And I have an LMA as backup, oral airway as well. And I have tape for taping the eyes. I'm going to introduce my patient. So this is Coco Goff. She's a 21-year-old female tennis player here. She's here for a ACL MCL repair via a knee arthroscopy. She is 70 kilos and 175 centimeters tall. We're using a cadaver donor graft for her knee today. And I'm going to be doing a femoral nerve block with a general anesthetic today. Her history includes a previous ACL MCL repair on the other knee, and then she has allergies to several drugs. And then I'm going to be reviewing her CVC and coags and pre-op and the rest of her medical history and chart. I'm going to go see my patient, and I'm going to do a full head to toe and auscultate heart and lungs. Then I'm going to ask her a few questions. Do you have any histories of paresthesias or stroke or seizures? Do you have any syncopal episodes or have any chest pain, shortness of breath, or heart problems I need to know about? Any history of asthma, any kidney, liver disease, or diabetes? Any exercise intolerance? What did you have for breakfast today? And have you had a recent cough, cold, or flu? Have you had a history of problems with anesthesia, such as post-operative nausea and vomiting, or any high fevers? Any family history of melena, hyperthermia, or high fevers? Have you ever been hospitalized? I'm going to do an airway exam and check her Malin potty, her upper lip bite test for incisor gap, and her thyromental distance, all within normal limits. And I'm going to explain my anesthetic plan for her today. I'm going to take you back to, we're going to do a femoral nerve block in pre-op, and then I'll do a general anesthetic, and you'll have a breathing tube in the OR. And some of the risks of a general anesthetic is that you can have longer immobility time, so that can lead to an increased risk of blood clot. And then you can have hemodynamic instability, airway injury from the breathing tube, such as like hoarseness with your voice or sore throat. You can have nausea and vomiting, or you can have respiratory complications like laryngospasm or bronchospasm. Some of the risks of the block that I'm doing is you could get some quad weakness, which could lead to an increased fall risk, and then you can also get last hematoma or vascular nerve injury. However, the benefits of using general anesthetic is that we can protect your airway from aspiration, and that you can also have more controlled ventilation in the OR. And with this block, you'll have a better pain control in the OR and post-op as well, and it really reduces the amount of opiates we have to use, and that helps reduce nausea and vomiting risk as well. And then it also helps with patient clinician satisfaction, and then helps get you out of the hospital faster. Some of the alternatives is you can do a spinal or epidural anesthetic, and you could also change the kind of block. So I could do like a sciatic or nerve block for this patient, or do an IPAC block if she's got posterior knee pain in post-op. So she gives me consent, and then I'm going to give her 2 milligrams of Versed and 50 mics of fentanyl and pre-op, and I'm going to put the monitors on and perform her block. So I'm going to gather my equipment. I'm going to do an ultrasound probe. I'm using Marking today, 0.5%. So I have that ready. I have my gel, I have ultrasound probe cover, and I have my nerve stimulator that I'm going to use as well for the placement today. So my landmarks for this technique is the inguinal crease, and then I can palpate the femoral artery, and the femoral nerve should just be lateral to that. And then I'm looking for 2 fascial layers, the fascia lata and the fascia iliaca, and I have to get my needle through both of those layers to get to the femoral nerve and provide adequate coverage of that nerve. So the patient's going to be lying in a supine position with the extremity like slightly rotated out. And then I'm going to perform a patient timeout before I start this procedure. And I'm going to put my PPE on and adequately prep and drape this patient to be sterile. And I'm going to do some lidocaine first. I'm going to palpate the femoral artery, and then just lateral to that, I'm going to do a couple lidocaine skin balls as well to help with the pain with the needle. And I'm going to be using a high frequency linear array. It's 10 to 12 hertz, and I'm going to be using an in-plane technique today. And I'm going to start by looking for my anatomy here. Okay, so you can see the femoral artery pulsing there. I'm just gonna, yeah, you can freeze it to your picture. And then the nerve is the most lateral structure here, so on this far side. Okay, so using my needle, I'm gonna use in-plane technique, and I'm going to insert the needle first, and then I'm gonna turn on my nerve stimulator, and I'm gonna slowly decrease the milliamps until I do not get a twitch. I should be losing my threshold about 0.4 milliamps or 0.5 milliamps. If I'm 0.2 milliamps, I know that I'm intraneural and that's not safe for injection. So then I'm gonna be doing, after negative inspiration, I'll do 5 mil increments around to really bathe that femoral nerve. And I'll do a total of 20 mils of 0.5% Marcaine. And that's within the safe limits for this patient, 70 kilos, and the Marcaine dose without AB is 2 mg per kg for a safe dose of Marcaine. Okay, so like I mentioned before, I'm going through the fascia lata, the fascia iliaca, and then I'm gonna put the medication between that iliaca and the iliopsoas as well. And you can see the femoral artery, femoral nerve, and femoral vein here as well. Okay. That's good. Here's your towel. Okay, so now I can bring her back to the OR for an induction. And I'm gonna get her in this nice sniffing position. The monitors are already on, and I'm gonna start pre-oxygenating for 3 to 5 minutes to denitrogenate using the EC technique. And I'm gonna put my O2 up to 6 liters, 100% over here. Okay, and now I'm gonna give my 100 mics of fentanyl, 100 milligrams of lidocaine, and then I'm gonna push 140 milligrams of rock. I'm going to make sure I have a loss of reflexes and tape the eyes. shot and deliver a positive pressure breath. And then I'm gonna give my 70 milligrams of rock, and I'm gonna wait for the onset of that, and now I can yell. And I can see the cords. I'm just gonna get the tube through the cords here. As they go through the cords, I'm pulling out the stylet. And I can see misting in the tube. I'm gonna auscultate for bilateral breath sounds. I'm looking at my capnography to make sure I have proper tube placement, and then I'm gonna tape the tube at 21 centimeters at the teeth here. And I'm gonna turn on my SIBA to 2% for maintenance today.